Hi, everybody. So, modern medicine has become a money machine designed to turn its suffering patients into, well, are we actually live here? Hold on one second. There we go. We are live.
Okay, there we are.
There we go. Let's start this over.
Much better.
Modern medicine has become a money machine designed to turn suffering patients into lifelong customers. I'm Dr. Danish Mazumdoost, a native Kentuckian and the visionary behind Wellward Regenerative Medicine. As a Johns Hopkins trained double board certified anesthesiologist and regenerative pain specialist, I believe it's time to bring true healthcare back into medicine and offer you, the patient, the healing you deserve. This 50 Shades of Pain show is one way we empower you, the patient, to receive sustainable treatments for injury and pain without surgery, addictive medications, and without being a victim of the system designed to work against your healing. We're here to help you start your healing journey at wellwardmed.com. Today I'm with my co-host, Dr. James Escaloni. Dr. Escaloni is a physical therapist who serves as a physician extender and a clinician at Wellward, a movement specialist. Like myself, he's seen firsthand countless of patients who have suffered unnecessarily, not for lack of quality or caring doctors, but from a broken healthcare system, one that's been fractured for many years among different disciplines. So James, what are we talking about today?
Glad you asked. Today we're going to be talking about the SI joint and those pesky ligaments that keep that pain around. So, for you guys at home, have you ever had that pain right below your belt line around the buttocks?
I'm not trying to show off my butt, I'm just showing you where.
Right around that area. Have you had that just seem to stick around? Have you ever felt that it seems like it goes out of place and then it just gets better, but then keeps on going out of place over and over again for years? Have you ever heard somebody say their SI joint is out? Well, that's what we're going to be talking about today. We're going to get your minds going around this new topic, and I think that should give you some good answers and head you in the right direction. All right. So, what we're going to be starting to think about is I want everybody to think about that SI joint and the ligaments that are around there. So, every single person around here has heard of an ankle sprain. An ankle sprain just means that you pulled the ligaments really firmly and far in your ankle. That's what happens every time you turn it. And if you ask people, especially soccer players, those are the ones that seem to have sprained their ankles. They keep on doing it, and it seems like it's a little bit looser, a little bit wobblier, and they're more likely to have that pain again. Well, that's what can happen at any ligament in the body, but especially at the SI joint. Mm-hmm.
Yeah, and a lot of doctors, they focus so heavily on degenerative discs and things that are very visible on an MRI, but the problem with the sacroiliac joint is it's not really well visualized on an MRI. People have this notion that in an MRI, it gives all the insight that anyone would need to understand what's going on in the body. But you have to understand how an MRI works. It's taking, or a CT scan for that matter, any kind of imaging and method, it's taking small slices throughout the body. And if the slices are cutting through a ligament where you're only getting a snippet of it, you're not going to get the continuity of that ligament unless you're able to catch a plane of that ligament that falls exactly in the plane of that MRI slice. So even, it's not like a 3D reconstruction of the body. It's just you're getting these snippets, these snapshots of the body, and then the radiologist is hopefully insightful enough to be able to recreate that three-dimensional image in their mind. But the reality is, when you're dealing with multiple complex overlapping layers of tissue, those kinds of 3D recreations are practically impossible. And I'll show you what I mean. This is a small app that I use to explain things to patients. I'm just going to use it to show people. So what we're talking about is this joint right here, the sacroiliac joint. Here's the sacrum in the center, and then here's the ilium on the side. See, I'm doing this backwards. That one, and that one. So these two joints are connected together with a complex of ligaments. And I'm going to go backwards so you can see how many different layers of ligaments there are in stabilizing this joint. Now, everybody understands sprained ankles, but sprained ligaments in the back don't really get a lot of attention. And yet they're one of the more common reasons people have chronic low back pain. And when we're talking particularly about the sacroiliac joint, this is a joint that has, you saw how many different ligaments they are. Well, all of these have to work collectively in concert to be able to create stability of that spine. And it's a really important section of the body because it's the junction between your upper body, your thoracic, like all of this, and your pelvis. So if that joint is not stable, you can imagine how just very slight variations in movement are going to translate to tremendous forces on that region. And if any one of those ligaments is problematic, it's a domino effect where it just kind of starts to unravel. So, James, I assume you see a lot of patients with sacroiliac dysfunction.
Tons of them. And one of the things that frustrates a lot of these people is they have pain for years. They go to get the MRI.
Nothing shows up.
It's nothing.
Yeah.
And so they don't feel like it's nothing, but then they start to think they're crazy.
Yeah.
And they're definitely not crazy. These types of things happen. And it takes somebody who has enough skill to understand that, one, this type of pathology exists, because some physicians, unfortunately, don't even believe this causes pain.
Yeah, I've heard that.
Mm-hmm. And it also requires that the clinician that you're seeing knows how to successfully do the testing for this.
Right.
But then afterwards, well, you got to get the right treatment. I know that earlier on in my career, I was taught that as long as you get the muscles around that tighter, that's all this person will ever need. And then later on, I was taught, well, if we take the joint and manipulate it, crack it, move it into place, well, that'll take care of it. But as my education has moved on, my evolution of learning how the human body has moved on as well, I know that for some people that can help, but it seems to be that for these people who that doesn't help, it's because there's still a loose ligament. The body can only move so far with those ligaments and the muscles to support it, but if the ligament is loose, it goes further, the muscles tighten up and spasm around the joint, and it can make the joint pull, it can make those injured ligaments pull further and have more pain around that joint. And as much as you try to strengthen it, as much as you try to push the joints back into place, there's still an injured ligament that's the cause behind the cause of your pain, and that is what needs to be addressed.
Yeah, so I'll show you what James is talking about. And it's not to say physical therapy isn't good. Physical therapy is necessary. It's just that ligaments are like stagnant stabilizing structures, meaning like if I'm standing still, primarily it's the ligaments that are holding me up. The muscles are just essentially doing coordination to prevent me from tipping over, but it's the ligaments that really maintain the integrity. And when you increase the strength of the muscles, what you're really doing is you're increasing the stamina of those muscles to act as like a secondary guard. So you can imagine, like, if these ligaments are starting to fail, the body has a lot of redundancy. The biggest muscle being that gluteus maximus. The J-lo muscle is what I call it. But beneath the J-lo muscle, there's just a whole slew of different muscles that can act as surrogates to these ligaments if the ligaments are failing. And these muscles start to contract. And the stronger you can make those muscles, the more secondary support structures you have. The problem is that these muscles might not be designed for or ready for the load that's being demanded on them when the sacroiliac joint fails. And when that happens, you start to get these areas here, which is where the tendon is attaching to the bone. Muscle becomes tendon, and then it attaches. Sorry, muscle becomes tendon, and then the tendon attaches to bone. But if these tendons are starting to weaken as they're being utilized more than they were designed to do, then they start to break down. And oftentimes, people with sacroiliac pain, they don't just have pain in this area, they start to have pain that radiates and wraps around and settles into this area on top of this area. That's because of that secondary support structure. Those muscles are starting to break down and cause other sources of pain as well.
Yep. And what starts to happen after that? You have pain that starts to extend even further down, because now all sorts of other joints are trying to twist and turn to try to figure out, how can we stop this person from falling down? Well, we're not getting enough support from the ligaments, and those darn muscles are getting tired of doing too much work, so they get pain that starts to shoot down into the legs. Other tissues start to get involved with this scenario. It becomes a big mess, especially the longer and longer you've lived with this type of thing. And then by the time you see a clinician, well, they don't even know where to get started with you because you're hurting everywhere. And let alone you don't even know where to get started with you because you're hurting everywhere. You could probably think you're crazy, especially with an MRI that says everything's fine.
Normal. Yeah. And what's even more frustrating is that people always talk about nerve roots being compressed or disc being a problem and causing that pinched nerve. But I've seen enough of these over and over and treated enough of them over and over where when I inject medicine directly around or on top of one of those ligaments that can be sprained or damaged, the patient will say, "Oh my God, I'm feeling the pain that I normally feel down the back of my leg." What that tells me is that not everything that radiates is a pinched nerve. In fact, I would say pinched nerves are fairly uncommon. And what's far more common is when you have referral pain patterns. The example I use for referral pain pattern is like if I was hammering a nail and I slammed my thumb with the hammer, it's not just the thumb that starts to throb and pulse, the whole hand starts to ache. And it's because the nerve signal coming out of here is so loud that my spinal cord and my brain really can't tell where it's coming from, and it just kind of says everything in the path of that nerve is problematic. So the nerves that go to those ligaments, they're going to other places as well, or they're connected to other nerves going to other places. And when the ligament is damaged and causing pain signals to be created, those pain signals are going to bleed over onto other things in the path of that same nerve. That's when you get that pain down your leg, and everybody starts to look at the disc of your spine and gets the MRI, and worst case scenario is that you have an incidental disc issue that's completely unrelated to the pain that you have in your sacroiliac joint, and everybody assumes that that's the problem because it just overlaps with the typical nerve root pattern that you would get with sacroiliac pain. I often see people who get surgery in those situations and it doesn't help with the pain. Big part of that is the proper workup wasn't done. The assumptions were that this is the cause of pain, or that the disc or the nerve root is the cause of pain, just because it's similar to the pain patterns you see with sacroiliac or you see with nerve root compression, but they can be completely different causes.
One of the problems that we start to see here is that by the time somebody has gotten to have this pain finally looked at again and again, and they start to see that something is going on an MRI, well, that's when you start to have some arthritis finally in the SI joint, and people think, oh, well, the SI joint must be the cause of their pain. And that's when surgeries for that are suggested.
Yeah.
Well, that could be problematic.
Yeah, I don't think a lot of docs who do understand sacroiliac as a potential cause of low back pain. In my conventional training, and I did some of the best training in the country, it was always taught to me that the sacroiliac joint becomes arthritic, and that to me is a little bit of a myth, because if it's arthritic, then we should be able to see some changes on X-rays and MRIs, because when you have a joint that's arthritic, it starts to grow like what we call osteophytes, or bone spurs, areas of the bone where it's just kind of becoming scraggly and ragged. But with sacroiliac joint pain, I much more prevalently see patients who are having these pain issues and having zero imaging findings. Like nothing shows up on the X-ray, nothing shows up on the MRI. And it's because these sacroiliac changes, like the arthritic changes of the joint, are very late stage problems. Much of the pain that people feel, or the greater degree of the pain, is from the ligaments being problematic. And I know that definitively because I've seen so many of these patients where we touch the ligament and they just go through the roof, but you numb the joint itself and it's not nearly as impactful as when you numb the ligament. This is a process that we call pain mapping, where we try to understand the origin of the pain and map it out to its different components, to the different individual gears and levers in the body that cause pain, as opposed to just making the assumption that because they've got some imaging findings, or because it's, you know, pain in the vicinity of the sacroiliac joint, that the entire joint is problematic. When you do it as a lump all like that, your outcomes fall because you're not able to differentiate what treatments are helpful to which patient group versus another patient group.
That's what it usually ends up when some physician is going to say, well, I guess we should just do surgery for that SI joint.
Yeah.
And then that's when patients don't get the outcome that they were hoping for, because that wasn't the source of the pain.
Yeah, we see that quite a lot. A lot of sacroiliac fusion has become more and more commonly done now. I see a lot of those patients, and I'm not saying that some patients don't need sacroiliac fusion. It's just that very few patients actually do. More often than not, if you can understand which ligament is problematic and start working on fixing that ligament, the fusion becomes unnecessary. And why is that important? Because joints that are mobile and dynamic are able to age with you. Once you fuse a joint, that becomes a fixed point in the body, and everything else up and down the mechanical chain has to accommodate that one point of fixture, as opposed to growing and evolving with you, or being able to be adapted to whatever the body's changing needs are as we age.
And it's a big deal because that will cause further and further problems for you that stem from this first surgery that you really can't undo anymore.
Yeah. Yeah, we've seen a number of patients where that was the case. Like, they fused that joint and the problem was coming from elsewhere. And now it's a more difficult scenario. I always recommend to patients, look at the treatments that you're being offered and decide which ones burn bridges. Because a lot of the treatments that we focus on at Wellward are minimally invasive regenerative therapies that are geared towards repairing the body. So your worst case scenario is minimal effect or no outcome. That's the worst case scenario, and even that's an uncommon occurrence. But when you're talking about surgery, or when you're talking about like burning nerves, you're talking about something that has a pretty dramatic impact on the body, which is sometimes not reversible. We do nerve burnings here all the time, and for people who don't know what that is, it's when we identify an area of the body that's problematic, we're not able to fix it, so the best that we can do is just numb that discrete area, that very small area, by burning the nerves that go into that area. It's not one of my favorite things to do. It's a more of a last resort kind of situation, because it's so much more common for us to be able to restore the functionality of those ligaments and be able to get people back to normal, back to functioning.
Mm-hmm. So I think that some of the audience might want to know a little bit more about what exactly is something that they can do for the ligaments that we offer specialty here.
Yeah, absolutely. So we've taken a very integrated approach. The reason that Dr. Escaloni is here on our team, along with the other clinicians that we have, is that what I do is help restore the functionality or the regenerative capacity of a damaged ligament. Meaning, what I'm trying to do is identify the specific ligament through pain mapping, and then use regenerative techniques where our goal is, rather than injecting steroids or using anti-inflammatories that suppress the inflammation, which then suppresses the pain, we want to understand what are the good parts of inflammation, what are the bad parts of inflammation. The bad parts being the painful parts. The good parts are the parts that actually stimulate the repair process, because every damaged part of the body goes through this process of inflammation, which then leads to proliferation, meaning that the cells in that area are starting to repair and grow. And then it goes into a stage of regeneration, where those cells start to regenerate and become more solid adult cells, and into rehabilitation, where those cells now learn how to interact with each other and become normal functioning tissue parts again.
Mm-hmm.
I can get people up to that rehabilitation stage. Then it's Dr. Escalone's role to figure out what's going to be the best way to rehabilitate this, because using regenerative therapies is not as simple as just squirting some product into a joint and then hoping for the best. We see that a lot. But what you really want to understand is, what are the mechanics of that body, of that part of the body? What can we fortify with regenerative therapies? And then how do we best rehabilitate that through the physical therapy, through exercises, through dietary changes, giving your body the building blocks that are necessary to repair injuries.
Sometimes it's good to think about it like planting a seed in the ground.
Yeah.
That seed is naturally designed to grow. But if you put a seed and put it in the middle of the desert, it's not going to grow very well. But if you take that same seed and give it the nurturing so that it could be given enough fertilizer, sun, water, protection from the environment until it can be a sturdy plant, then it can handle anything. That's this process. The regenerative medicine is that seed that's naturally going to get in the right position so it can heal you. But when you put the good rehabilitation in all the right times, you stress the tissue in just the right way, you give it everything that you need along that pathway in a way that nobody else in the country is doing. And that, I promise you, this makes this cell better, stronger than they would elsewhere. It's an amazing thing that I'm very, very proud of that we do over here every single day with our patients.
Yeah, our goal is to get people well enough where they don't come back and see us. This whole business model of pain management, where patient comes back on a monthly basis, to me was going against my conscience. And that's the way I was trained, is that people don't get better. Best that you can do is just minimize the pain or minimize the impact of the pain. And I just flat out rejected that model. And what we're really doing is, we want to empower patients to understand their bodies, because your tolerance for pain is limited by your understanding of what's going on. I've seen people endure amazing sources of pain. I mean, running marathon or an ultra marathon, those people feel pain along the way, but they have an endpoint in mind. They know what to expect. They know what the outcome is going to be. And when you know what you're dealing with, it's so much, your tolerance for pain goes up so much. So what we want to do is help them understand their bodies, demystify the body, but then also work towards optimizing its capacity for repair, so that you can go back to being who you are, connecting with the person that you feel at your core is who represents you, as opposed to letting the pain be what dictates what you can and can't do. So everything that we're trying to build in our system and our institution is geared towards empowering patients and helping them be the best that they can be, rather than rely on healthcare to keep them going.
So if you are curious anything about the SI joint, ligaments as a cause of your pain, we're right here over at Wellward. So feel free to reach out to us. And we're at www.wellward.com. This is our website where you can reach out to us. You can learn a little bit more about us. You can see some of the success stories from other patients who are probably like you, who were decided that they were done with pain and they wanted to do something about it to change their lives.
Yeah, and if you have any other questions, you can always reach out on our Facebook page or find us on our home page and send us a message. We're getting more and more patients requesting appointments through our webpage, and I encourage you to do that. Thank you, everyone, for watching 50 Shades of Pain, the 50 Shades of Pain show. Each patient is different, and there are numerous factors that can contribute to your pain. In the same way that we recognize each patient as an individual and create treatment plans that are designed specifically to tailor to your health, we hope that you will help us expand the message of what we're doing, because our goal isn't just to treat our own patients. We want to be the living laboratory that sets the example for all of healthcare to really change and rally around the patient as an empowered, healthy individual for whom our role is the guardians of health as opposed to the people who treat disease. Our Wellward team looks forward to partnering with each and every one of you, and I'm Dr. Donish.
And I'm Dr. Escaloni.
And we encourage you to start your healing journey at wellwardmed.com. Thank you, everyone. Till next time.
See you next time.